Assalamu alaikum. Can you hear me?
Walaikum assalam, Doctor.
Yes, Doctor. Yes, we can hear you.
So sorry, obliged to come back to the ICU because to be beside one baby. I tried to go down to the clinic to give you lecture on good internet. Hoping inshallah it will be okay. We can start now by Al-Kitab. I didn't prefer to speak alone. So every time and then I will ask someone to comment or read slide. So keep in contact, please. Okay. How many candidates today? You are 36. Still there is one missing candidate?
Yes, there is one missing, Doctor. I believe it's he has
this 36 including. Okay, let us conclude for that at the end of our presentation. Can you see my screen?
Yes, Doctor, we can.
Doctor, we can.
You can? I cannot hear you. Is it clear, the screen now?
Yes, clear, Doctor.
Good. Because this is a different type of presentation, I'm trying to make it full screen. Okay, just to remembering you as a Muslim, praying to Allah every time, and then it is a very good practice here in Malaysia to always in the meeting after pray to raise your hand and to pray for yourself, for your family, for your colleagues. All this is working and very important. Please don't underestimate it. Here is dua you used to pray with it. اللهم افتح علينا أبواب حكمتك وانشر علينا أبواب رحمتك وامنن علينا بالحفظ والفهم سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Today we are going to speak about the gastrointestinal tract examination. Okay. From this slide, who can comment about that picture, please?
The abdomen is divided into 9, can be divided into 9 regions.
Good. So what is this 9?
So we have a right hypochondriac region
Okay.
on the top right.
Okay.
And then we have epigastric region, a left hypochondriac region, and then followed below by a right lumbar region, umbilical region, left lumbar region, right iliac region, hypogastric, and left iliac. And within each region of the abdomen, it lies different organs. So I think it is significant for us to know the organs that lies within each region. Should I pinpoint the organ, Doctor, or is it enough?
No. Good. It's good, Athira. So 2 things, please.
So
As
the organs.
Athira told now, we need to know in every area, what is the suspected, just a while. Hello? Yes. Yes. I have to check now. Let our staff meet here until I finish. Okay. Okay, bye. So number one, to know which every quadrant or every piece, we must know what is the organ can be palpated here. Okay. The second thing, really we must consider it 10, not 9, the one which intact for the genitalia, especially in children. You can find a lot of problem. So you must look for the genitalia for small babies, but for any adolescent, you must be very sensitive, okay? The third thing, which is very important, any scar. If you found any scar in any quadrant of this, you must ask yourself, is it upper and right? It can be scar like for cholecystectomy, for liver transplantation, if in the appendix side, if in the back. So a scar is very important because no one is going to have a scar without surgical intervention. So it is a big and important point, okay? So every part of the body of the abdomen, you must know what you are searching for, like for the liver, where you are searching for the liver.
Right hypochondriac and epigastric.
This is the normal liver. But if it is enlarged, so liver will enlarge it as if it is going to the right iliac fossa. Sometimes if the liver are very big, you can palpate it near the right iliac fossa, okay? That's why we are starting our examination for palpation of the liver, not from umbilical or like that. You must start down from the right iliac fossa and come up until you touch the liver, or if you cannot touch. If you touch, you need to check the upper border to define the liver span. Am I clear? For the left upper hypochondrial area, which organ you need to examine? Here. It will be the spleen primary. Also spleen, if normal, it is below the below the ribs. But if it is enlarged, it will enlarge in that direction, going to the right iliac fossa. So for both liver and spleen, you must start from the right iliac fossa. But the direction up or going to the other side to check is it liver or spleen. It is very important because some candidates, they got a very huge hepatomegaly, but they didn't start from here. So they are palpating, they cannot. Some of them said there is no hepatomegaly, and he may fail at that time. The other one, he said, there is no hepatomegaly, but on palpation, it is dull. So what you must think about, really, I don't know. So ask him, calm down. When he calm down, oh, liver is 13 centimeter below the costal margin. It is very dangerous to miss that, okay? So this is number one. The organ, the scar is very, very important. Here is the second important clinical skill is the observation. This one speak about the scars, which we just speak about. So I need one of you, especially of my group, did the most common abdominal scar, okay? What can be behind it? And send it to my ment-to-ment group or to the all group, please, okay? What you can see in this picture?
Scleral jaundice.
Scleral jaundice.
Very, very clear, yes. But sometimes in the exam, and sometimes in the actual life, because you are a bit hairy, you can miss it. So if you find this eye jaundice and you find this child in the middle, what is this? What you can see? This one.
Thalassemic faces.
Yes.
Chipmunk face.
So we have malar prominence, we have mongoloid features, we have all this of thalassemia. So if I find anyone in Malaysia with jaundice and thalasssemic face, I must, number one, my diagnosis is thalassemia, yes. If I found this liver, it is confirmation, but this liver, if you are going to palpate, you will find it very huge and come down. But sometimes it is the abdomen is not prominent and it can deceive you. What is this? This is blood
Sickle
film.
cell anemia.
Okay, so
Anemia.
yeah, you must be able to use all your tools to come to the conclusion. Even this chest X-ray. What does it tell us? They call very common description, hair on end. The bones looks like it is hair standing on its end, okay? And it means there is bone marrow are hyperactive. So it will be appear in the X-ray like this. So by one observation, you can diagnose a lot of cases. By just scar, you will ask yourself, if this patient has this scar in this left hypochondrial, which can be the splenectomy scar, mustn't miss it. Okay? So be a good observant, please. Oops. This is how to be soft and try to make the patient relax to be able to examine this organ, which is this one is
The liver.
is this one is the spleen. As I told you, you must start from the right, but you are going to the left side, and this is the kidney. Sometimes you need, if you cannot palpate it, and you need to turn the patient to the side, can be also, okay? So now we are introduce the importance of pediatric clinical skills, which we just spoke about it yesterday. Yes, focus in the disease, interview with the patient, and history taking must be warm and friendly without interruption, with good eye-to-eye contact, with listening, with observation, with empathy, with support, with logic flow. All this is your job. If you start from now, for the coming 1,000 a day, I hope you will be very pioneer in your job, inshallah. Introduction, nothing in the world can go like one shot. You must make a good introduction with the family and you be able to ask a different style of questions to get the truth. No excuse for you at that time for two things as we spoke yesterday. You must have a definite flow to putting the history and also definite flow to examine the patients, okay? In name and gender is very important to know is a boy or a girl, because even X-linked disease like that, okay? You must have a good dress and good speech and have both arts of differential diagnosis and speaking with the family. Equipments are very important. I am remembering you again, please don't miss. It's your weapons, okay? You are not allowed to lose your weapons. To be professional, again, your appearance, your manner, your kindness, your highly responsibility. You remember the moral from Islam and from the medical career, which we have its moral and its regulation, which must be respected, because Islam are respecting for every subspecialty its own points. You must be confident. Don't forget to hand rub for between every patient and after patient. Okay. Try patient became tired if you are not taking care. So take care. Does your patient has a pain? Does he become tired? Okay. Make him comfortable, please. And expose only the recommended parts. Again, to examine the abdomen or any organ after observation from the bed side, you must stand to the right side of the bed and examine with your right hand. Okay, you must have your sequence of examination. You must give a good exposure. You must take care to his disease and answer any question of the patient. Don't neglect it, please. Okay. Don't forget to compare both sides, because it will guide you. Even there is some disease known as hemihypertrophy. Part of the body is bigger than the other. Usually we are not 100% equal, but there is high similarity. But if you found it completely different, you must ask yourself what is behind that. Observation of the patient is very important. If the patient looks ill or well, dysmorphic or not, good nutritional or not, he is alert or not, he is comfortable, okay, any distress. It is very important for signs of dehydration, as we spoke yesterday, okay. He looks clean and well served, because child neglect can be even picked from certain points. It is very important to get that one. During palpation, take care during your all clinical examination. You are not allowed to give pain to the patient. So you must ask his permission, and you must ask again, does it hurt you anywhere? And even if he said no, you must look to his face. Maybe he is suffering under your hand, which may be strong, which may be cold, whatever. So you must take care about that. Okay? So you must be sympathized. Your hand must be warm. Okay? Any palpation, it must be superficial and then coming to be deep one. Don't go for deep palpation rapidly. So again, just to revise, number one, general survey or observation, and then make sure the room is comfortable with temperature. You have towel to cover the patient. You use a good light, so you are able to pick like jaundice, like tinge of cyanosis. All this need a good lighting. Okay, looks and observe before touching and completely expose the body part you need to inspect, but keep the dignity of the patient. So abdominal examination, we must know that is, if you did it a well-conducted exam, you will get a great amount of knowledge. But if you did it poorly, you can get nothing. And even you can lose the confidence of yourself and your patient. Everyone develop his personal technique, but you must know the flow. If you don't know, also, if my mentor group, we can ask them to make like their flow of examination, okay, which will help us to know if I am examining the abdomen today, I must do 1, 2, 3, 4, 5 until 10, 15, no issue. I have 15 or 20 items. I will go it in sequential. And my job, it will be, I will pick the findings from everyone to collect it together to get the diagnosis. Am I clear for that?
Yes, doctor.
Okay, so it is very, very important, please, to plan for that. You can open here video, one for adult, one for pediatric abdominal examination. It is very good. And the link in the last slide. So now you are asked to examine the gastrointestinal tract or the abdomen of this child. How you approach? Number one, introduce yourself, get permission, hand rub or hand wash, expose your patient and in a good position with keeping dignity. Then comment is well or unwell. You can comment about conscious level or other. What about his nutritional status? And always, you must have opinion. You must say this child looks small, looks underweight, or the other child looks obese. I would like to plot him in centile chart. We'll go the gross chart or centile chart, which will help you because you must have your opinion, but you must put it to the standard. Okay, so you must go through his nutritional and gross. Is there any attachment like cannula like that? Is there any dysmorphic features or not? Usually mucopolysaccharidosis will have a lot of findings like hepatosplenomegaly, like skeletal abnormalities. Then you must get a look for the skin. What is the color? Color of the skin, all this can give you a clue. If it is sallow color of renal failure, if it is yellow for liver and jaundice, if it is green, it is obstructive jaundice or direct hyperbilirubinemia. If it is brown, it can be deposition of iron inside the body. What about the body hair or facial hair? It can occur with cyclosporins. Okay, about the skin rash, like dermatitis herpetiformis or telangiectasia, all this, even pigmentation like the coffee or lace spots can appear in the abdomen. And you must know that skin and the brain, both of them are coming from the ectoderm. So there is a long series of diseases now known as neurocutaneous syndrome. Meaning you will find the clue in the skin. When you search, you will find other abnormalities in the brain. The most famous one is the neurofibromatosis. Is there any nutritional support, like the patient still have NG tube or TBN, okay? Or this one, which is very important, percutaneous endoscopic gastrostomy. Some are calling gastrostomy tube, GT, or percutaneous endoscope gastrostomy tube. It is very practical one. If which is patient with a chronic neurological problem like that child with cerebral palsy, he cannot suck, and you will find the clue that he is drooling his saliva and he has stiffness or like that or spasticity. So instead of putting every time OGT tubes, just we bring through the endoscope one catheter inside the stomach, and the family will prepare the food and put it through that one. Okay. Many things you can good about it. Even if you are looking for the nappies for pampers, diapers in the small children, if there is incontinence, if the child has even diarrhea, what is the color of the stool? Is it bad odor? Does it contain any blood or not? It is very important. So I observed the patient and I comment about all that generally, about dysmorphism, about the skin, about the nutritional support. And then I will start from peripheral. So number one, introduction. Number two, start from observation, then start from peripheral. Peripheral means by the hand. So I will tell the patient, hi, give me 5. So he'll give me his hands. I will go through finger clapping and ask myself, Is it there or not? How is the stage of it? How can be behind it? And I must comment about the nail colonicea for iron deficiency or leukonicea for cirrhosis. It is very important. Also, I will go for the palm for any erythema associated with chronic liver disease. Is any pallor? Okay, is there any hepatic flab, which is liver failure or renal failure or CO2 retention? The arms also are very important. Okay, if there is tuberous in the elbow area or the soma, okay, all this can guide you for hypercholesterolemia. Okay, bruising can be developed either ITP or the patient has chronic liver disease. Is there any scratch marking? Scratch marking will occur with cholestatic jaundice. It is very important. Spider nevi also has its own importance. So I will start from the peripheral, start by the hand and the palm and then the arm, and then I will go up. Before going to the eye, I must go to the head to observe if there any abnormalities in the head or not, and then come for the eye. You must comment and you must ask yourself, don't make it as a routine without picking the, because if it is mild anemia or mild jaundice, you can miss the it. So this is important to answer about for observation. This is sometimes some patient has abnormality in the copper metabolism, so the copper will be high and it will be deposited in many areas in the body and cause nervous system affection, and it can cause liver disease, and it can cause psychological disturbance. And in the eye, you will find in the eye like this ring around the black of the eye, which looks like copper. If you saw it once, even in the book, you will not forget. So sometimes if you are a good observant, you can pick a lot of things, okay? Is there any plethora in the face due to chronic liver? Is there any cyanosis or hepatosplenomegaly? All these are very important. Then you will come to the mouth. Is there any pigmentation? There is one disease or a lot of disease like Behet's syndrome, okay? Is there any ulcer, which can be simple abscess ulcer, or it can be Crohn's disease or celiac disease or Behet disease? You know this Behet disease, which is ulcer in the genitalia, in the mouth, like that. Is there any gum hypertrophy, which can accompany leukemia or some medication like phenytoin or cyclosporin? You must comment about the tongue. Is it a big size? So you may suspect thyroid function test or blood sugar for Behet-Weidman syndrome or mucopolysaccharidosis like Crohn's disease, and a lot of series. What about glossitis? If there is inflammation of the tongue, it can be either iron or folic acid or vitamin D deficiency. And then go for the neck and the chest. Is there any spider nevi or gynecomastia? Gynecomastia can occur during puberty in some boys, but take care, it is not chronic liver disease. So I would like to choose one now where the group is not appear in mine to comment on this inspection. Yes, I have 35, still 35, not more. Okay, Adib Irshad.
Yes, doctor.
Go ahead and comment for this inspection of the abdomen, please. Remember that we already finished the introduction, the observation, the peripheral, okay, which you started by the hand until came the face and the mouth, and even after that neck. And now we are going to inspect the abdomen itself. Go ahead.
So for the abdominal inspection, the shape of the abdomen is very important. As for children or adults with malnutrition would have what do we call that? Scaphoid abdomen. And For distension, if it's generalized distension, then it can be due to ascites, for example. Can also be due to hepatomegaly, splenomegaly, often both. If for 5Fs, okay, so for 5S is for the extension of abdominal distension. It can be due to feces collection, sometimes even gas collected or flatus. It can be due to fluid, as I said earlier, for ascites. Nephrotic syndrome will also cause ascites. And if there is fetus, is it, for example, like a twin, doctor?
No, even one baby. I mean, if you find the abdomen distended, many candidates CDs, there is ascites, even before doing the shifting dullness and the transmitted thrill. If distension can be 5F, this is your basic medical science you just finished a while ago, and you just passed the initial GRO or first GRO exam. Okay, so it could be like constipation, abdominal distension and malabsorption. It can be a bit of obesity and like Cushing syndrome. It can be fluid like ascites. So remember, it is not single. And this is another advice: don't accept single diagnosis in your life. Even if you diagnose any patient, ask yourself always, what can be the first differential diagnosis? It will increase your ability or your thinking inventory, okay? Diagnostic thinking inventory. You will be able, okay, go ahead.
If for obvious masses, it can be a tumor in the liver, and obvious masses. Can it also be a hernia, paraumbilical hernia? If scars, it can be a sign of a previous or history of surgical intervention. If it's below right subcostal margin, it can be due to past cholecystectomy or hemihepatectomy. And for rooftop scar, it can be due to liver transplant if the patient's having past autoimmune liver diseases or hereditary liver diseases and needs liver transplant. For transverse upper abdominal incision, it can be due to a repair of congenital diaphragmatic hernia, which is more common on the left. If it's upper abdominal or midline incision, it can be due to Nissen's fundoplication. If it's small right upper transverse incision, then it's Ramsted's pyloromitomy. And if it's around the umbilicus, we can consider gastrocysts or exomphalos, or it can also be the umbilical hernia repair. And if it's laparoscopy scars, a very common one, and also lateral thoracolumbar incision, which can be nephrectomy for previous history of renal damage or renal failure. That's all, doctor.
Okay, thank you. So now, could you pick how many knowledge you can get just from observation? I think all of us are not in need to jump to the patient when I ask, examine the abdomen. We will jump directly and start by palpation for the liver. No, please come back with one step or be on the bed, the leg side of the bed, and get observation of all these things. Okay. Next one. What is going on? Can you present from your side? Maybe better. Hello? You can get a few minutes to prepare presentation from your side. Just a minute with the patient and I come back. I will come back.
Okay, doktor. Siapa nak present ni?
Nak aku present ke?
Kau dah nak dah?
Tak kisah.
Okay, boleh.
Ha. Oh, tapi doktor kena stop sharing dulu sebelum aku boleh share.
Tu lah. Kena bagi tahu doktor depan ni.
Assalamu alaikum. Hello.
Waalaikumsalam.
Should I switch off my screen?
Yes, I can share my screen.
Stop share, okay. So sorry, we're just counseling one patient to turn to palliative care because of Edwards syndrome. Your job will be very chaotic with time, but it is with Ajr, inshallah. Yeah, very good. So we spoke already about the inspection. For inspection also, we must check for stria. Stria, it means you will find like streaks in the abdomen. If you remember during ONG, you will see something known as stria alba because the stretching by the fetus. Here, if there is stria rubra, it will accompany some cases like steroid toxicity and Cushing syndrome. Okay, caput medusae are very important. If there is blood vessel around the umbilicus, it is called as caput medusa, but you must be able to define how is the direction of the blood, toward or away or from the umbilicus itself. So it will guide you, is it from superior vena cava or inferior vena cava? If there are any stomas or ileostomy, so you must know what is the type of stoma. I think during the surgery we'll go about that, but for us, you will see the scar, okay? And the scar will guide you what type of stoma. Sometimes the ability to blow and his abdomen, it will help you to pick if there any hernia, especially it is umbilical or inguinal hernia, okay? Also, it will help for that. Most of the kids may have divercation of recti. I mean, when they are with their abdomen, it is not very strong. There is like gap, but with time, it will be improved. Okay, next. Can you hear me?
Yes, doctor.
Okay. So for inspection, we finished already. We know how many jobs we must do. Then we are going for the palpation. Palpation divided into two types, superficial and deep. I just put this one picture for you to know how you are dealing with the superficial inspection. The patient should be on supine position. However, if the patient has gross ascites, you may want to ask him whether it is comfort for him to lie flat, or you can change that one. Be sensitive. I mean, don't be sensitive. Be sensitive for the feeling of the patient. You must tell him, I am going to feel your tummy. Please let me know if you feel any pain. If you need me to stop, tell me that, because some are a bit shy to speak about you, but they are feeling pain. If the examiner see you while you are continue examination and the patient continue to have expression of pain on his face, he cannot pass you. So you must look at the face of the child during examination. And you must stop and apologize if he experienced any pain. If you adjust the position, if you are told like that, okay? After that, you will palpate systematically for the deep palpation. As we specified before, please don't forget to start from right iliac fossa. Sorry, it is written wrongly. From the right iliac fossa, okay? The second. slide. The deep palpation, is there any organ or is there any mass or tumor? Again, your hand must be warm. Especially some ladies, their hands are very cold, so take care please to prepare your hand, okay? And ask him if you feel any pain also. Liver palpation and percussion. So we'll start from the right iliac fossa until the right subcostal margin, until you feel the edge. Ask the patient to take a deep breath and try to feel the liver edge as it descends, like it came to your finger edge. If you feel the mass, describe the surface. All of us forgot to do that job. Number one, that the liver is coming with breathing, coming down to my finger. This is number one. Number two, I must describe, is it smooth surface or nodular? If it is nodular, you must think about something dangerous like tumors or others. What is the consistency? If it is just soft, maybe more benign, but if it is hard, what about the edge? Is regular or irregular? So you must be able to comment at the end, this patient has hepatosplenomegaly, blah, blah, blah. The liver looks soft, moving with respiration, and its edge are regular, like that, okay? Then you must percuss again from the right lower quadrant to the abdomen and define the area, okay, of loss or dullness or loss of percussion resonance, and from up, and you must measure the liver span. Is it clear? So you must do the job accurately. First by palpation, second by liver span. You must notice here something important, that many babies, you can palpate the liver, but it is not enlarged because they have weak abdominal pain. So you can just palpable. Okay, so we are doing the liver span to say how much is it. If it is bigger, you must consider. The second thing is some diseases of the chest with severe hyperinflation can cause dropping of the liver. It is not hepatomegaly. So you will palpate the liver like 1 or 2 centimeters below the costal margin. So how can you differentiate? It differentiates also by the liver span. So the liver span are very, very important. But if you found liver palpable more than 2 centimeters like that, you must consider it is hepatosplenomegaly, not it is dropping, unless you're able to prove by the measuring the liver span. The most important thing also, please, don't think this liver are enlarged 4 fingers below the costal margin. Which finger is it? Is it your finger? Is it my finger? Is it small finger? It is a big finger? No. We must standardize. So you must bring your meter and measure, please. By tape measure, how many centimeters? Am I clear? If you went outside and cause any fault of that, you will be accused. Okay, next one. Okay, it is not so clear, but for the spleen, you are going to measure also from the right iliac fossa. Remember that the spleen usually cannot palpable under the costal margin unless it is enlarged 3 times. Okay, so percussion are very important, but you must start from here because sometimes the patient has 5 centimeter spleen. You must palpate at that direction. Tropes area are very important, and there is a video I wrote it in the end. Okay, can you decrease the size of the slide, please, or move it right or left? Oh, okay, it looks cannot be. Okay, okay, no issue. So If the patient are obese, your job will be more difficult, but you mustn't feed up. But take care that this area are very important, but its sensitivity and specificity is not so high. Okay, so you need to do drops if it is dull and you cannot say it is due to other causes. You may consider is a part of the splenomegaly. Okay, for the kidney, we cannot say how much the kidney is enlarged because it is intra-abdominal. But if it is palpable or palatable, we will consider it enlarged. How to feel it? You must put one hand at the back, one hand in the front, and try to palate. I mean, you push by your hand from down to palpate from up and like that. Okay? And repeat it in every side. If you are able to palpate, you will assume that this patient has enlarged kidney. Okay? How to differentiate between liver and spleen and the kidney, we will speak about that. After you finish the three organ, and please remember, we are commenting about three organ, liver, spleen, and the kidney. Many of you are missing the kidney. Even at the end in the exam, we're asking them, what about the organ? Yes, no hepatosplenomegaly, doctor. Okay. Any organ do you need to examine again? No, I forgot. Even he is examining for nephrotic syndrome or nephritis. So it is very important to comment about the kidney. And then don't forget to continue your job. In the job, we said it is inspection, palpation, percussion, auscultation. Okay, so percussion for the abdomen are very important. The most common two is the shifting dullness and the auscultation for fluid thrill. Sorry, for fluid thrill, palpation, percussion for fluid thrill. After that, auscultation for the bowel sound. Remember that as we spoke yesterday, the bowel sound is only few per minute, like 5 or 6. Sometimes we can hear liver bruit or renal bruit if there is severe hypertension or like that. So remember that also for auscultation. Next slide. I think this one is self-explanatory. How can we differentiate between liver, spleen, and the kidney? Is it clear? Who is moving with respiration? It is both liver and spleen. Okay? Usually the kidney are also resonant, but liver and spleen are dull. So we have now two criteria, or there is one more for the kidney, which is resonant and doesn't move with respiration. But for kidney, for liver and spleen, you cannot get, I mean, if you feel here any dullness in the right iliac fossa, and while you are coming up, it must be continued until the ribs. For liver or spleen, if you found resonant dullness and then resonant again, it may be another mass, not the liver. Okay, the difference here, or the kidney, you cannot get above it. Remember that the spleen has notch, which is very important. If it is enlarged, you will feel, especially if it is firm, you can feel it easily. Okay, here the kidney is bilateral, the liver at that direction. So please try to remember this, an important slide which will guide you how to differentiate between the major three organ and how you will be specific during examination. Next. How to perform a palpation, it is very important to deal with the babies if they are afraid for their rigidity or resistance. Okay, so if the abdomen is lax, okay, try to decrease voluntary muscle tightness or actual rigidity. It is very important. Try to distract the child as if you can speak with him. Okay, so we will attract his attention. Sometimes if the patient, after you examining him while he's extending his leg, you cannot palpate, so you can ask him just to make flexion of his hip, slightly flexion of his hip and knee. It will help you to relax the, of course, don't cause any pain for the patient. Okay, all this just to decrease the voluntary muscle rigidity. Next one. I spoke here for percussion and auscultation and others. Percussion, we speak about for these two, shifting dullness. You must know how to do it clinically on the patient. Okay, fluid thrill, how to do it. For auscultation, as we speak about the bowel sound, the liver, renal, what other? You must check, as we said before, external genitalia. Is there any hernial orifices, especially if indicated? It is not for every patient coming to us. We will go look for that until the issue is related to the abdomen or the patient has criteria of delayed or precocious puberty like that. But the hernial orifices are very important. If you suspect surgical one, external genitalia, sometimes you have some cases like congenital adrenal hyperplasia, which can get premature precocity. You must check the back and the perineal area also if needed. You must, inspect the diaper of the patient for color of the urine and the stool. Okay. For the renal examination, you must get a look for the urine and the blood pressure. Don't forget that in many cases, steroid toxicity can be detected during abdominal examination with striae rubra and others. So you are not finished, even you are doing, you introduce yourself and observe and start from peripheral and go for the organ, and you did again inspection, palpation, percussion, auscultation. You must ask yourself what other, like if there we suspect beating edema, we must check for hernia, for abnormal genitalia, for the back, for even the diaper for small babies, and others. Okay, next. You can read about that, please. I put this one for you. What be the causes if you found hepatomegaly? Either it is structural or storage or metabolic disease, hematological one. It can be heart or vascular one. It can be infection. Then next one. This is a splenomegaly. If you come to splenomegaly, you will feel it looks the same, but with different priority. Hematological problem like lymphomas and other myeloproliferative disease, which is malignancy. We are calling now myeloproliferative disease for tumor, because we found if you tell the family cancer or tumor, sometimes it looks shame for some patient and they feel unhappy. So we just try to put the name which is bit covered but understand. Proliferative disease, it means disease which is evolving without control. I mean, without my control. So it is very important. Is there any also hemolytic anemia can cause that? Extramedullary like case of thalassemia, infections, okay, some parasites like malaria and Kala azar and toxoplasma or inflammation, some autoimmune disease like rheumatoid, SLE, sarcoidosis, can be even idiopathic like ITB, maybe portal hypertension. We'll speak about that with one word after that, and some inborn errors. So it is mixed. Sometimes you find the liver alone. Sometimes you found spleen alone. And the third slide, the coming slide, is the together. Okay, what if I found even hepatosplenomegaly, even I can find ascites with it. So I'm going to speak about the main pathology maybe in the liver, like cirrhosis, fibrosis, biliary atresia, like that. It may be hematological, it may be infection, maybe malignancy, maybe metabolic or storage disease. And the ascites are very important to consider. Why this patient got ascites? He got any liver cirrhosis, he got any congestive heart failure, he got any hypoalbuminemia, he got any infection like TB, any malignancy, any pancreatitis. So now I need you to be broad-minded. If you find the spleen alone, how you are thinking. If you find the liver alone, how you are thinking. If you find both, how you are thinking. Okay? It is very, very important, because if you are doing like that, you will be able to pick the simple difference and come to the conclusion more easy than you are broader. Next slide. Next. This is just one word about the portal hypertension. Can you hear me?
Yes, we can, doctor.
Yes.
Oh, come back, please. Come back. The previous slide. You cannot. Yes, this portal hypertension, really just remember it is very important. If there is hypertension in the portal circulation, it will be presented by splenomegaly, sometimes with ascites, okay? And there is porto between the hepatosystemic circulation, like caput medusa. You must put it especially in some congenital cases in pediatrics, because causes of portal hypertension can be pre-hepatic, hepatic, or post-hepatic. Okay, the most common pre-hepatic is the portal vein thrombosis. It can occur in adult one, or cirrhosis, or fibrosis of the liver, or post-hepatic Budd-Chiari syndrome. I think you will see it in internal medicine more, and heart failure. But don't underestimate the probability of portal hypertension if you palpate the spleen, please. Next slides are giving you just a guide how to think, please. The issue which I asked you, it looks a bit complicated, but it will let you think how you are handling the patient if you are examining the gastrointestinal tract. Introduction, general inspection, and then you are going to peripheral, like upper limb and the head and that, and from the abdomen you will start again inspection, palpation, percussion, and auscultation, and then you ask yourself, what else, like in the lower limb I need to see, other I need to see, okay? If you are systematized, you will find it very, very simple, and I will tell you it will be like something good and give you a good humor. Second slide, you need to read it, please, because everyone may need lecture on its own. This one, if you are going to also exam of the abdomen for another things, because sometimes you are just examining the abdomen, you will find like rash, okay, of or in the buttock area and like that, with some joint affection. So you must able to think about the cause of that, okay? line purpura usually is the most common cause. Sometimes I asked you to examine the abdomen for a small scar here. And if you look to the head of the child, you will find his head are big. So he has hydrocephalus and operated by ventriculoperitoneal shunt. So you'll find the scar down. So everything can give you knowledge. So please revise this one, which is very important, how to examine the abdomen itself. Next, or the third one, is the examining of the small children, sorry. Okay, so how can we examine the patient if has jaundice? It's just to give you the same sequence, but while you are concentrating on this one, maybe in your 5th year, because now, but I think neonatal jaundice still can come to you during the exam. Okay, but mainly it is for 5th year for neonatology. Next slide. Allahu Akbar, Allahu Akbar. Before I was giving the nutritional lecture, but here how to apply it. Okay, how to assess if the nutrition of the child or good or bad, he is under nutrition or he is obese. It is very, very, very important to you to go through this one. So I just give this 4 pictures for you, just to go through it, and it may be, inshallah, during our bedside teaching, we will remembering you for that, or ask you for that. Next one. Again, don't forget to pray Allah for your lovely one, please, and for all Muslims. Next. Someone can present the first case. Zakwan. Oh, Zakwan. Can you hear me?
Yes, we can, Doctor.
Where is Zakwan Rahman?
Yes, Doctor, I'm here, Doctor. Doctor?
Hurry to read this one for your class.
I'm not sure.
Just read first.
A 14 months old breastfed male infant was noticed to get puffiness in lower limbs and loss of smiling. He was mild hepatomegaly, mild ascites, and no jaundice. His serum potassium was 1.3 milli equals per liter. Sodium 128 milli equals per liter. Blood sugar 56 milligram per deciliter. Plasma albumin 1.5 gram per deciliter, and hemoglobin was 8.3 gram per deciliter.
Okay, so by observation, what you can see, Zakwan?
This patient has edema of lower limb.
Lower limb only?
And the abdominal distension.
Okay. Also the face looks a bit puffy also.
Yes, he looks puffy too, his face.
But the muscle, even of the upper limb and the lower limb, looks like wasted. So this is false swollen. If it's swollen because if it's a good nutrition, it will be different. Okay. So observation are very important. So this child has edema in the face, abdomen, and the leg. And at the same time, if you read again, has puffiness of the lower limb and loss smiling. It means the behavior of the baby is not good. And by examination, I told you that he got liver ascites, but no jaundice. Now I am going to check the investigation. I found the potassium are low, sodium are low, blood glucose is acceptable. Plasma albumin is low, but not so low, and also has anemia. So the next slide. So if we come now, the diagnosis, it will be protein caloric malnutrition or kwashiorkor. Okay. What is the important differential diagnosis? Can be renal edema, which is either nephrotic or nephritic. Important lab, I must ask for the albumin and the cholesterol to rule out nephrotic. Three causes, three complications. If the patient are under nutrition or severe edema, he can get infection, he can get electrolyte disturbance, and he can get hypothermia. So now we know how to think, how to use our thinking inventory to look for the patient, to get the most important knowledge by just observation, and then come back to the history and investigations. Okay, the next slide. Who can read, or should I choose? Okay. Who is one Noor Shazwani? Noor Shazwani. Can you read this question for your colleagues, please?
I'm here, Doctor. So, a 9 years old boy has fever, excessive somnolence, and severe anorexia with vomiting and abdominal pain. He has yellow-colored urine, skin and sclera. The liver was fat 5 cm below costal margin, soft and tender with no splenomegaly. So, serum ALT 345. Serum AST 623. 4.9 milligram per deciliter. D
Conjugated.
deconjugated 3.7 milligram per deciliter, and PT was 16 seconds.
So what is your interpretation now? Okay, so can you hear me?
Yes, we can, doctor.
So it is very important the age of the child, his complaint, okay, and now he can find has a jaundice, and the liver is palpable, and all this is the liver function test, which is very increasing. Okay, so this is the age with child can eat outside. They didn't tell us he has like thalassemia like that. So if you come to the answer, next one. So the diagnosis, we must suspect hepatitis A. At sometimes in many areas in Malaysia, we got like epidemic of hepatitis A because of the people who are eating outside if they got any source. This is the normal for the investigation, okay? And how can we confirm? We need IgM and IgG for hepatitis or PCR. But don't forget that any disease can cause organ affection, so this disease can cause fulminant hepatic failure. Okay, how to protect? There is extra investigation given at the age of 1 year against hepatitis A. It can be given for anyone, even adult like us. It is a single dose. It will give, بإذن lifelong immunity. Okay. I will leave the remaining one. You can read either together or everyone alone. It is very informative for you. And hoping, inshallah, I will discuss it with you after we finish our clinical practice together soon, inshallah. Okay, thank you. Now it's your turn if you need to ask any questions.
Doctor, I have a question.
Yeah.
Do we have
Yes.
to do external genital examination every single time, or when it's necessary only? Can you hear me?
And from the patient, of course. Don't go directly to exam.
Sorry,
Unless
doctor,
you
can
have some
you?
suspicious, you said I need to.
Oh, okay, okay. Thank you, doctor.
Yeah, if you have, if you feel that there is during the exam, you need to exam in short case. So you must ask me, doctor, I would like to complete my exam by checking the external genitalia. Of course, you can check for hernia by easy, still the genitalia are covered. But if you are going to examine the genitalia itself, you must ask permission from the examiner. And if he said, okay, you must get permission from the family. Okay.
Okay, thank you, Doctor.
Any other question? If anyone didn't attend today, she must contact Farah and give her excuse not to attend, please. Okay. Thank you, and inshallah meet you soon in the hospital. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.
Assalamualaikum.
Thank you, Doctor.
Thank you, Dr.